Hi everyone. Welcome to the NEET SS 2024 Rheumatology Recall session. So, as you might obviously know, it's been almost a week since the exam, and rheumatology was a major player this time. Unlike, we'll see how the question weightage was in the previous years, but this time obviously rheumatology is one of the major talking points, and that's why maybe we are a little bit late coming into the recalled questions. So first things first, weightage, as I told you, it's almost one-fifth of the paper, almost 29 questions. That is every 1 in 5 questions rheumatology was being asked. Uh, Compared to other years, it has almost like more than doubled from 2023. And if you look at 2022 was the first time when the NEET SS, the new pattern came about, where there was mixed pattern of all topics, all subjects. And that time it was only around 10 questions, and most of them were predominantly, if you look at it, not really testing, as in they were not differentiating questions, except maybe pigmented villonodular synovitis was one question which was a little bit difficult, but otherwise there were more or less very simple questions that were not determining your rank. Then we came to 2023, where it became 14 questions increased, with again SLE APS having 3 questions, other CTDs like Sjogren's, systemic sclerosis, MCTD, all of those having more questions. So that was what the hot topics were with respect to your previous year questions, your SLE APS, other CTDs, and a little bit of RA, etc. But this time, if you look at it, compared to other topics, SLE APS was ignored to a great extent. Other CTDs kept their weightage. But now, if you look at the previous years, immunology, for example, was very, very less. Immunology, including drugs, was only 1 or 2 questions, but now it is almost 5 questions that is there. Obviously, there is overlap with pulmonology, etc., which we will discuss, but the weightage has increased now. And spondyloarthropathy, RA, including, these two arthritis, having 10 questions out of a general medicine paper of 150 is, I think, quite a lot. So that also, there's been a massive increase with respect to the hot topics this time. Topics left out cold, SLE maybe I would say, and maybe compared to RA, spondyloarthropathy, myositis maybe might have had one more question. Vasculitis was ignored quite a bit this time. Usually NEET SS papers from previous years, if you look at them, vasculitis was a hot topic always, but that has also been ignored now. So as you can see, 10, 14, 29 is how rheumatology is increasing. This time another, I'm not saying rheumatology will hold this weightage. Obviously, this is a kind of an extreme thing that has happened now. But what I feel is, especially when there are 3 blocks to a paper, and I assume that 3 different sets of examiners are there because the distribution is varying quite a lot in between blocks, right? So I feel every examiner, whatever specialty he is, will think about rheumatology in medicine, right? So I feel that was one major reason why rheumatology came quite a lot. All the paper setters of all 3 blocks might have been thinking, okay, rheumatology has to be there in some form in a medicine exam. So I think that is why so many questions have come. So if this pattern follows, then you can expect rheumatology questions to be at least 15 to 20. 30 is a bit too much. I think it was an exception. And yeah, I think in a way it's okay, because not many people read rheumatology specific textbooks like Kelly's, etc., and like very few people give the exam. If it was the other way around, like if it was something like other specific specialty, like for example neurology or cardiology, getting 40 questions or something, then those specialist INISS preparation students might have got an unfair advantage, right? So that is one positive takeaway. So coming to questions proper, we'll look at where the questions are coming from, and also if we look at, we'll look at the takeaways as well. Oh, so yeah, just give me a moment. Yeah. So firstly, we'll start off with SLE APS. Again, as I told you, 2 questions only. This was very straightforward, just an APS question with DVT, acute ischemic stroke, and the questions were, very straightforward. Low molecular weight heparin, with or without warfarin. So with, or obviously you will eventually go to warfarin, right? Thrombotic APS. And another, one of the option was warfarin without LMW H. That also you would not do, because you will have to have a heparin bridging to prevent warfarin skin necrosis, etc. So low molecular weight heparin has to be there first, bridged, followed by warfarin lifelong. So that is what we do for thrombotic APS. We've discussed this in our WhatsApp group also, how to divide APS into thrombotic APS and obstetric APS. Thrombotic APS, always you have to plan for warfarin lifelong. That is the end goal, depending on the current status. If the currently the patient is just obstetric in a pregnancy, then you will obviously give LMWH till pregnancy is complete and then go to warfarin lifelong. Here there's no such complication, simple thrombotic APS. You have to bridge with LMWH followed by warfarin. There was some question with respect to INR. INR is 2 to 3 or 2.5 to 3.5 depending on the guidelines. But whatever it was, I think one of the option was without LMWH was one of the options where there was given INR. So this is definitely wrong, and A is the correct option. So this we have obviously discussed we've discussed in the NEET SS videos itself, the thrombotic APS, whatever type of thrombosis there is, you have to plan for warfarin. Depending on if there is recurrent thrombosis, then you will go for 3 to 4, otherwise you will just go for 2.5 to 3. Then I think the simplest question of this paper with respect to rheumatology: female with malar rash, anti-dsDNA antibodies are there, ANA is positive. So very, very simple. SLE, no need to discuss this much. Classification, diagnosis, whatever you keep, it will be SLE only. This is all again almost a neat PG type of question. Swan neck deformity. So this also we have discussed, swan neck versus bottom-neck, where the hyperflexion occurs, hyperextension occurs. Again, no need to discuss much. Maybe somebody might have gotten confused with mallet finger. I don't think so, because mallet finger, again, there's no hyper extension at the PIP that is there. So only there will be a DIP involvement only. So here there is clear hyperflex. I'm not sure if this is the image, but supposedly it was classic hyperextension at the PIP also. So that doesn't happen in mallet finger. So these are the slides. I've put slides, whatever we have discussed in our, NEET SS videos, just so that you can pause and look at the answer. If ever you have confusion with respect to the answer, then you can look at these slides as well. Next was RA, chronic RA patient for 10 years on treatment, now presented with a non-healing ulcer on the lower limb and glove and stocking neuropathy. The only confusion here, obviously, there is no drug-induced neuropathy because there's no drug mentioned. It's not a diabetic neuropathy, nothing as such mentioned. The only confusion might be between these two. But the only thing is, for 10 years, even if it is 10 years, amyloidosis is not very common, right? So firstly, amyloidosis is not very common in general. Secondly, something should be given for you to think about amyloidosis in an RA patient, apart, like, excluding RA vasculitis. For RA vasculitis, there's no exclusion here. It is looking like a possible, highly likely RA vasculitis only. If you have to rule out RA vasculitis, there should be something, right? But there's nothing given. There's no, something like membranous nephropathy, some other, characteristic amyloidotic neuropathy features, maybe autonomic involvement. Nothing like that is given. So it is RA vasculitis. Clean and clear only. It's not a very much confusing option, and we clearly discussed that this glove and stocking polyneuropathy is something that definitely can happen in your rheumatoid vasculitis, apart from having a long-standing disease and positive RF-ACCP antibodies. So this was one thing that I think some students were confused whether this is there or not there. Yes, it is possible, manifestation, peripheral neuropathy with either mononeuritis multiplex or a diabetes like glove and stocking polyneuropathy. So these are various extra-articular manifestations that and so this was the confusion here. Amyloidosis was the confusion, but again, there's no mention of any renal involvement, so that you can exclude. So this also you can look at it. Amyloidotic neuropathy, this case only sensory is mentioned. There's no autonomic involvement, etc. And systemic involvement there is no mention of it. Skin ulcers is not typical of amyloidotic neuropathy. Again, here skin ulcers were mentioned, and yeah, it's much rare compared to your RA vasculitis. So 60-year-old male presented with RA on methotrexate for 5 years, presents with progressive breathlessness, dry coughs, characteristically possibly ILD, because HRCT has also given traction bronchiectasis, reticular opacities. So this was a little bit out of, a little bit higher level, maybe, because it's definitely not given clear cut in your Harrison. So firstly, methotrexate induced fibrosis is not common. If you go through the lecture here, I have clearly mentioned that methotrexate-induced fibrosis or drug-induced or methotrexate-induced pneumonitis, it is very much low in prevalence. These were my exact words. So that you can rule out first itself. So this is definitely wrong. Then end inspiratory course crepitation. So course is the word here. So this is more or less a overlap question between pulmonology and rheumatology. So course crepitations don't occur. Course crepitations are much less characteristic of your ILD. So coarse crackles are more characteristic of your bronchiectasis, medium crackles more characteristic of your COPD, and early inspiratory medium crackles more early to mid inspiratory crackles more characteristic of your COPD. And when you come to late crackles, if you have pulmonary fibrosis or ILD, fine Velcro rail like crepitations are Velcro rails or Velcro crepitations are what we usually hear, and they are more characteristic of ILD. So drug this also you can rule out. So maybe the confusion might have been here, but if you look at it, we did discuss about your prognosis of your RAILD compared to IPF, UIP, it is better, but in general, NSIP versus UIP, NSIP is much better prognosis because it responds to immunosuppression. UIP doesn't respond to immunosuppression, while your NSIP does respond to immunosuppression. So that maybe it's a little bit of in-depth question, but again, if you are strong with respect to your pulmonology, you can understand that honeycombing pathology, whenever it occurs, it's more of a damage. Even if a patient has honeycombing, even if you give him severe strong immunosuppression, that will not reverse. So that is one, that is in comparison to, for example, ground glass opacities. They will reverse or at least become static or at least dissipate to some extent with immunosuppression, but honeycombing will never reverse, and that is why we call it irreversible damage. So this is the correct option here, and likely to respond well to steroids, when especially when UIP is mentioned, that is also not a correct answer. So I think here biopsy was also mentioned. I'm not sure. I think here biopsy showed UIP pattern, if I remember the recall correctly. So that clearly it was a UIP based question. So definitely honeycombing, irreversible damage, there's no doubt about it. That is definitely the correct option. So these are what we discussed: UIP common patterns, heterogeneous fibrosis on biopsy, and honeycombing on radiology, NSIP as GGOs, and second most common in RA. RA UIP is more common than NSIP. So poor prognostic factor in RA. So this I'm pretty sure this is like a wrong question only, because all three RF, ACCP, joint erosions, these three are definitely poor prognostic markers. And clearly in standard rheumatology textbooks like Fogberg's, it's been mentioned that there's no RCT or meta-analysis or any proper validated study that gives a weightage to each of these risk factors, right? So among these, which is the worst prognostic factor, there's no such validated data. So early methotrexate usage, again, long duration of disease is a poor prognostic factor, but early methotrexate usage is not a poor prognostic factor. At least it's not mentioned anywhere clearly, right? So even if you think about it logically, early methotrexate usage, if you're giving long term, there'll be better prognosis, right? So this is definitely wrong. But again, clear cut recall was that which is a poor prognostic factor, it's not which is a poor prognostic factor, except. So I would say this is most likely a wrong question only, and I think most of, like, everybody of you would get marks for this question, unless it except was written, then answer would be 4. So these are the poor prognostic factors. Main thing that I expected, maybe not in NEET SS but INSS, they may ask you that female gender is a poor prognostic factor for for RA. In ILD, male gender is a poor prognostic factor, but RA, female gender. Advanced age at onset of diagnosis, yes, that was one option that was not given. High RF, high ACCP, then early radiographic evidence of erosive changes, all of these are poor prognostic factor, which was mentioned in the question. So this is a very important slide. We discussed this in detail. This is not given clearly in your Harrison, but this is a repeatedly asked question. Especially if you look at things like this, these are not given in your Harrison clearly, but clinically they are very important. They are asked very frequently in quizzes, very frequently in vivas. So this is a very important topic in general. So predictors of disease persistence versus disease severity, these both are also different. I don't think they will get into this, but again, because now this has become a repeat topic, repeat question, you can definitely go through this as well. So this was what we discussed, again indicating good outcome. RFACP negative, as you can see, the disease activity is somewhat quiescent, while if it is high titer RFACP, then the disease activity keeps increasing, right? Again, this was, I think, one of the easier questions. Female patient presents with RA, is on triple therapy, methotrexate, sulfasalazine, HCQ, planning for pregnancy. So obviously, we have discussed this in depth. Sulfasalazine can be continued in female patients. Definitely, HCQ can be continued, while methotrexate has to be stopped. So that is the so stop only methotrexate, no need to stop sulfasalazine. All the drugs you have to remember. This is again, even in NEET SS, this has been asked previously in your SLE. I think 2021, one recall question was there that if you are actually on SLE treatment, what has to be stopped? Same question was there with SLE patients. So again, same thing, which immunosuppression, what to do in pregnancy, what to do preconception, what to do breastfeeding. This is a very, very important topic, and you should know this particular table. Again, you can I think I've posted it 3-4 times in our group, so that also you can go through. So especially these drugs are what the list you should remember, which are not compatible with pregnancy. Then coming to spondyloarthropathy, again, 5 questions were there in spondyloarthropathy, really surprising. But compared to RA, I think RA was a little bit difficult. In-depth questions were there, and also as we saw, one wrong question was also there. In spondyloarthropathy, but they were much more straightforward. So most common cause of reactive arthritis. I've told this while we discussed also spondyloarthropathies. They are focusing more on your peripheral spondyloarthropathies compared to your axial. Axial, whatever question they've given also, that is almost an MBBS level question. So they are not focusing on our axial. Previous questions also, if you see, same keratoderma blenodacicum is a clear direct repeat question of your NEET SS 2022. So they are focusing on your peripheral only. So reactive arthritis, even 2023 also, I think psoriatic arthritis was asked, not the axial spondyloarthritis. So reactive arthritis, diarrhea, dysuria, very simple. It's not syphilis, it's not streptococcus, mycoplasma, etc. It is salmonella. So these are for enteric: salmonella, shigella, yersinia, campylobacter, Clostridium difficile. These are your main organisms that cause enteric, post-enteric reactive arthritis, where chlamydia is your main organism for your post-venereal reactive arthritis. So then coming to again asymmetric oligoarthritis is there, dysuria, diarrhea, almost same question only, which is the most commonly associated one. So among this, it's obviously keratoderma blenodacicum. This is a direct repeat of your NEET SS 2022. I think NEET SS 2022 they had given image and all. This time I think there's no image, but again, very important question, no doubts about it. Always remember, sarcinoid bellinitis, keratoderma blenodacicum, both are seen in acute as well as chronic symptoms, while your oral ulcers is more in your acute one. So yeah, these are images as well. This is your keratoderma blenodacicum, your sarcinoid bellinitis. These are also very important questions. This has been asked before as well. Then coming to another peripheral spondyloarthropathy, psoriatic arthritis. So DIP involvement was mentioned, no skin manifestation was mentioned, and new bone formation was mentioned. So two important concepts were mainly tested here. Even if you ignore the DIP, you may say DIP can get involved in other things also. First of all, options were much easy. They didn't confuse you much. So psoriatic arthritis, firstly, remember that there can be a certain percentage of patients, around 7 to 15% of patients, where skin manifestations may not develop. So arthritis will precede skin disease in these patients in 7 to 15%. So that is a very important concept that they tried to test here. Secondly, what are the main radiological manifestations? So radiological evidence of juxta-articular new bone formation, that is basically new whiskering occurs at the bone joint margin. So that is your main classification criteria as far as your radiological domain is concerned. So these both were the main things that were tested. And DIP involvement, obviously, it's much more classic of your psoriatic arthritis, what we call as the Ray pattern. I think Ray pattern was also asked in, I think it was one of the INIS's general medicine questions. So Ray pattern also is seen in your psoriatic arthritis, where all the joints of a single finger are involved, right? So that is also there. Then so SAPHO syndrome, I think this is again a little bit in depth for your NEET SS. It is given in your Harrison's, it is given in your end of spondyloarthropathy chapter. So even if you remember that it's given at the end of your spondyloarthropathy, one guess you can say that spondyloarthropathy is what is the initial most treatment, it's NSAIDs, right? So that is one way where you could have thought of. Firstly, I'm not sure if SAPHO syndrome was given as your stem, or these clues were given. I'm not clearly sure. Any which ways, once you get to the diagnosis of SAPHO syndrome, it this is what we discussed. So pustulosis will occur, acne will occur, and there will be hyperostosis, osteitis, all of this will occur. Uh, right, so that is what is your main SAPHO syndrome. And here we discussed clearly, if you remember, we discussed bisphosphonates is a previous year question. Again, it was an INISS question, but that also they specifically asked that in bisphosphonates, in SAPHO syndrome, for hyperostosis, what is the drug use? That was the previous year question. So I did focus on bisphosphonates there in my lecture, but the first line treatment is always NSAIDs. It's always NSAIDs because it's a spondyloarthropathy phenotype, right? So first line, obviously NSAIDs. Previous year question was bisphosphonates. Maybe they'll ask you again about bisphosphonates in for hyperostosis, but first line treatment is always NSAIDs. And if NSAIDs doesn't work, then you go to TNF alpha inhibitors, bisphosphonates, etc. So this was, I think, I'm not sure if this bull head sign was given or image was given. I think that also you can help with, but this also we had discussed in our lecture, that bull head sign. This is a very important quiz question. That's a very common quiz question. So that is also important. Bull head sign is seen in SAPHO syndrome. Then yeah, so this was an again very easy question. Just axial spondyloarthropathy, classic symptoms were given. Most of you didn't even remember the stem of the question exactly because it was very simple and options were also not confusing. So I'm not sure if this is the stem, but just to kind of tell that it was a very simple stem and the diagnosis was ankylosing spondylitis. Needless to say, it was very easy, right? Then we come to vasculitis. I think vasculitis and myositis, only very few questions were asked. So firstly, yeah, so this was something that we discussed quite a lot on the day of the exam also. PR3 positive vasculitis, so GPA basically. What is the induction treatment? What is the most important initial treatment, right? So if you look at Harrison, if you have read Harrison only, actually it's much easier. If you have treated patients, if you have looked at various guidelines, then you may get confused, right? So firstly, just see the patient, bilateral lung nodules are there, hematuria, RBC cast is there, RPGN is going on, AKI is there, lung nodules are there, that is pneumonitis is going on, possibly diffuse alveolar hemorrhage is going on, and it is GPA. So firstly, it is severe GPA, right? Clear cut, there's no doubt about that. Secondly, so severe GPA, whenever is there, methotrexate cannot be used, evocapan only cannot be used, right? So these are what you use for your non-severe GPA when just skin is involved, or mild constitutional manifestations, mild ENT manifestations, then you use these lesser agents. So these both are directly cancelled. So here confusion was with respect to two. Do you give pulse followed by prednisolone and cyclophosphamide, or you give oral steroids and rituximab? This was the two confusions. Apart from that, there is also this mention that rituximab is superior to cyclo for all patients. So firstly, this line is kind of a red flag. So superior to all in all patients is definitely wrong. Firstly, whenever there is very severe AKI, whenever there is no extremes of age, right? So and there is no issues with respect to availability, there's no issues with respect to fertility. When all of this status is there and there is a very severe disease, cyclophosphamide is better in compared to rituximab. In the contrary, when there is more of relapsing disease, when there is extremes of age, when there are fertility concerns, all of this is there, then you prefer rituximab. So it is always a dilemma what to use, whether it be rituximab or cyclophosphamide. It is superior to cyclophosphamide for all patients is definitely wrong. So this is wrong firstly. Then you look at the other thing, when clearly here pulse is mentioned while here oral steroids is mentioned. You can give oral steroids, but there the dosing has to be mentioned. It has to be mentioned at 1 mg per kg at least, right? If you can't give 0.5 mg per kg. And by default also, if you look at it practically also, mostly in such a patient, you will go for pulse steroid, right? So definitely one here is the correct option here. So if you look at Harrison, what we discussed here, much another confusion was oral versus IV cyclo. That also we just discussed in our WhatsApp group. Oral can be given. It's not like oral cannot be given, right? So oral cyclo, if you look at Harrison, it is preferring or it is mentioning only oral cyclo firstly. Secondly, it's saying that even oral cyclo is better, even better than IV cyclo. So this is based on one trial only. This is based on one Cyclops trial only. So you can't say that for as a blanket statement. But still, even if you just read Harrison's, clearly you will go for cyclophosphamide in severe disease, cyclophosphamide induction for severe disease of GPA. So this is again a generic one. I'm not asking you to trust this, but mainly what you can gather is to rule out your methotrexate and avocapan options. So rituximab induction versus cyclophosphamide induction we did discuss. So that is also a very important one. Remission maintenance is a separate story. There, obviously, if cyclophosphamide was there in the options, then you could have ruled out. So yeah, IV cyclo is Ritux versus cyclo. I told you when to prefer Ritux, when to prefer cyclo. IV versus oral cyclophosphamide. Again, it depends on the cost. It depends on the compliance issues. It depends on the leukopenia. Whenever there is lower whenever there is lower WBC counts, you prefer IV to oral because again, that means regular monitoring, etc., is possible. Now coming to other CTDs, your Sjogren syndrome, Sjogren syndrome, systemic sclerosis, etc. So firstly, we have two questions on fibromyalgia. Fibromyalgia is an important topic. It's turning out to be an important topic for NEET SS because 2022, 2023, one question, and again 2024, two questions have been asked, right? So, but again, very simple questions, I would say. Pain worsened with activity without any systemic features is wrong. There'll be multiple systemic features that are there. For example, headache will be there, central features will be there, muscular features, systemic features, all of these will be there. If not, always there will be some complaint, some generic complaint, generalized complaint will be there. Then with swelling and stiffness, swelling is not so common. It will be a very subjective sensation of swelling may be told, but on examination there will be never be swelling. Joint pain with prompt temporary response to NSAIDs, again very wrong. So these are indications of something like your inflammatory arthropathy, right? So these are not your fibromyalgia. And increased pain sensitization is increased sleep disturbance, multiple comorbidities, clearly falls into fibromyalgia. So I think this was not, I don't think this was a very complicated question. At least the options did not make you get confused, right? So this was a very simple one. This also widespread pain, multiple tender points, fatigue, sleep disturbances. Again, you will not do this. All these radiology, etc. Again, they have given the options very carefully only. If you look at the Harrison table also, they have mentioned you may consider these things. ANA for SLE, for Sjogren's, for RFACCP, you may consider, but these are only when you are guided by a history and physical examination. So here you obviously have no specific indication for doing all of this. You have a clear-cut widespread pain, you have fatigue, sleep disturbances, directly looking like a fibromyalgia, and you should firstly apply fibromyalgia diagnostic criteria. So here again there is a confusion. There was a confusion that whether you have to rule out RF before doing a fibromyalgia blind diagnostic criteria, because obviously it's a diagnosis of exclusion, right? But here the point is there is clearly mentioned no signs of joint swelling or systemic inflammation. So he's clearly telling you when you are not getting guided by history and physical examination, then you don't end up doing these particular tests. So that is the important point. And obviously you have there should not be any confusion with respect to diagnostic criteria, classification criteria, etc. We have discussed diagnostic criteria in a little bit depth because this has been asked before. So widespread pain index, symptom severity scale, all of this you should apply and then see if the patient is falling into fibromyalgia diagnosis. Then IgG4 related disease, again, I would say a little bit difficult question because next step is asked. And if you went through our lectures, it would be actually very simple because there I talked about only two drugs, high dose steroids and rituximab, because only these two drugs have been mentioned in your Harrison. If you have treated patients, if you have read a lot more than Harrison, then you might get confused with methotrexate. Dapsone is definitely not mentioned anywhere. If you have read rheumatology textbooks up to date, maybe you would see methotrexate somewhere. But when you go to the standard textbook of rheumatology, again, Kelly's, if you see, there's no mention of methotrexate. There's only, as has happened in MMF there. So methotrexate, high dose steroid, obviously it's not like the next step, right? Once steroids have not, there's no response, you would not give high dose steroids immediately. So definitely you would go for rituximab here. And it's clearly mentioned in your Harrison's also that second line therapy for steroid resistant cases or relapsing cases, you will go for rituximab. So steroids, maybe you will continue steroids, not that you will not give steroids, but rituximab is definitely your next plan that you are looking at. Right, so watchful waiting, firstly, it's not a very severe disease, so it's not like you have to go and pulse the patient and suppress his activity or something. You can plan rituximab, and then along with that you will taper steroids. So watchful waiting, then you first line is steroids, then you will go for second line, which is rituximab. So yeah, this was a question that I just got, very late. So I'm not sure if this question was asked. If this question was asked, well and good. Again, not a very straightforward question. So firstly, diffuse cutaneous systemic sclerosis, clearly given as the diagnosis. What is the domain involved? Pulmonary domain is involved. PFT, FVC, DLCO is decreased. So some ILD is definitely going on, but it also mentions there is pulmonary hypertension. So here we don't know whether this pulmonary hypertension is primary or it is because of the lung involvement, that type class WHO class 3 pulmonary hypertension. We're not sure clearly. So for now, because there's no mention of RVSP, there is no mention of the severity of pulmonary hypertension, we can consider that the primary pathology here is actually ILD. ILD may be causing this pulmonary hypertension because of the fibrosis causing pulmonary hypertension. So that is a fair assumption, definitely a fair assumption, especially because there's no mention of the severity of pulmonary hypertension. So here the treatment focus will definitely be on your ILD. So ILD treatment focus, again, if you once you make this decision, the answer becomes much simpler. Confusion would be between only these two, and because of scleroderma renal crisis, usually you do not prefer systemic steroids as your frontline agent. So systemic steroids you can give in your systemic sclerosis ILD, not that you cannot give, but again, because of the risk of SRC, your immunosuppression should be your main target of treatment. Your thinking process should be in the line of MMF or cyclophosphamide. Along with, if there is significant fibrosis, you can think about nintedanib as well. So that is what is your main treatment modality. Again, we have discussed very focused approach only, systemic sclerosis ILD. Just think about MMF, just think or cyclophosphamide along with nintedanib. Only this much you need to remember in this case, right? So risk factors are important here, and your initial therapy, monotherapy or combination with MMF or cyclophosphamide along with nintedanib, as simple as that. Then we come to this again. I've taken a lot of pulmo questions. I feel maybe you can put this into pulmonology. You can put that end inspiratory crackles, coarse crackles. That is also somewhat pulmonology. There is a lot of pulmonology rheumatology overlap here. Actually, maybe a lot of pulmonology questions came into CTD, ILDs, etc. Possibly. So lung biopsy, yeah. So this was, I think, the question where lung biopsy showed UIP, not that one. Yeah, so lung biopsy showed UIP pattern, and here clearly there was an X-ray where lower lobes were involved. So lower lobe involvement versus upper lobe involvement, we have discussed very nicely. I've given you a mnemonic also. Upper lobe is charts, lower lobe is braids. So charts is Kohlberger pneumoconiosis, hypersensitive pneumonitis, ankylosing spondylitis, radiation, TB, sarcoidosis. So mainly most of your CTDs per se, whatever we call as CTDs, involve your lower. So only sarcoidosis and to an extent ankylosing spondylitis also, it is upper lobe predominant. Ankylosing spondylitis is not very common, but whenever it is common, whenever it occurs, ILD will be upper lobe predominant. So this is upper lobe ILD. Lower lobe ILD, it is braid. So byssinosis, RA, asbestosis, drugs, scleroderma, all of these, idiopathic pulmonary fibrosis, all of these are your lower lobe ILD. So here what was asked is lower lobe was mentioned, and all of the following conditions can cause lower lobe except. So here sarcoidosis would be the best, because sarcoidosis usually leads to upper lobe ILD. So upper lobe ILD, lower lobe ILD, again, very important clinical question, not very much focused upon in your Harrison. I'm not really remembering what was given in your ILD in your pulmonology chapters, but in your rheumatology, ILD lower lobe upper lobe is not clearly focused upon, but it's a very important previously asked question as well as clinically important. This was one question that Vijay Kumar sir, Karthik sir discussed. So I think this is predominantly endocrinology question only, but the answer turned out to be sarcoidosis. Sarcoidosis something is that is a disease everybody is fighting for. So I just kept it here. So yeah, so here fatigue, weight loss, these both are again possibly a sarcoidosis, and there was polyuria, low sodium and low cortisol. Something is happening with respect to your pituitary stalk abnormality that is happening, and that is causing your decreased pituitary hormones, that are tropic hormones that are coming. So it looks like ACTH has decreased, looks like possibly TSH has decreased, possibly your diabetes insipidus is happening. All of this is what is thought about. Serum calcium is normal was maybe a confusion, but as we discussed, calcium uh, in your sarcoidosis only in 10% patients only. your calcium will have a higher levels in your serum. So hypercalciuria, hypercalcemia will be seen only in 10% of patients. So normal calcium is absolutely fine. ESR normal, again, it depends. A lot of times ESR is not, very 100% sensitive or something. ESR can be falsely low as well. So that is what was tested. So I'm not really sure if this is the stem and all, but this, whatever this stem, best answer seems to be sarcoidosis. So here we did discuss anterior hypothalamic disease is possibly a common thing that occurs in your neurosarcoidosis. This can lead to diabetes insipidus and basically any anterior hypothalamic abnormality that can occur. Yeah, so this is the main thing that we discussed. Coming to myositis, very simple. Again, maybe if you've not read myositis, obviously it might seem difficult, but here also I told you, clearly mentioned that this has been asked in NEET SS before, can be asked in NEET SS again, because clinically very important. It's been given very inconspicuously in your Harrison, very small its place it has been given, anti-MDA5 only it has been given, severe palmar rash, digital ulcer, rapidly progressive ILD, that is what was asked, rapidly progressive ILD. Other antibodies are also important actually, but fortunately they have asked a very straightforward question, rapidly progressive ILD, anti-MDA5 antibodies. So this again, this is an important table, whether you're preparing for NEET SS, whether you're preparing for INSS rheumatology, whatever it might be, this we did discuss in our lecture also, and this is important because repeatedly myositis antibodies are asked. Crystal and other arthropathies, again, two questions on gout. Surprising because it's not very, very important that two questions are asked, but okay. So, acute onset monoarthritis, severe joint pain, erythema, swelling, suggestive of gout. What is the gold standard? So, gold standard, again, it's not been mentioned clear cut anywhere, neither in your guidelines nor in your textbooks, but what has been called as one of the criteria is your sufficient criteria. So, what is gold standard? Gold standard means once we get that, it's done, diagnosis is done. So that also you can kind of relabel it as your sufficient criteria, right? So this is what ACR, your latest classification criteria for your gout says, ACR classification criteria. There is a mention of sufficient criteria. So sufficient criteria is presence of MSU crystals in a symptomatic patient or symptomatic joint or bursa. And there you will basically take the synovial fluid or tophi and you will do synovial fluid analysis. You will get needle shaped negatively birefringent crystals. So entry criteria is you're something that firstly the patient will come to you only if there is some pain, swelling, tenderness, etc. Right? That is obviously there. But what is sufficient to call it as a gout? That is presence of MSU crystals, and hence synovial fluid analysis will be the best answer here. So entry criteria, sufficient criteria, and then once sufficient criteria, if sufficient criteria is not there, for example, you're not able to get synovial fluid or your polarizing microscope is not available, whatever, then you can use these step 3 criteria, where again clinical criteria will be there, lab criteria will be there, imaging criteria will be there. These are not gold standard. These are just weighted criteria. These are criteria that have a certain weightage. It's not like once that is positive, directly you will go for gout diagnosis. It's not like that. But this is sufficient. That is presence of MSU crystals in your synovial fluid. Then again, preferred initial treatment of your acute gout episode, very, very simple, indomethacin. Again, this also we discussed, mainly you start early, within 24 hours, you treat for days to weeks depending on the flare, and usually urate lowering therapy, if it is already going on, then you may continue, you need not stop it, but definitely in gout flare, you will not initiate urate lowering therapy, mainly your three basically drugs will be there: colchicine, NSAIDs, and your immunosuppression in the form of glucocorticoids. So these are your three main drugs that are there. So start early, treat for days depending on the flare, and ULT I told you about. So colchicine, NSAIDs, and your immunosuppression. Next, a patient comes with fever, arthritis, salmon-colored rash on the trunk, and decreased CD28 expression. So, firstly, you can kind of, even if you do not know this disease, I think the patient was here, I think patient was 30 to 40-year-old. That also I have, just got a 30 to 40-year-old patient was there. So, firstly, you can rule out juvenile idiopathic arthritis. Even if you have heard JIA somewhere, you would know that JIA is less than 16 years, and new criteria it's less than 18, right? Juvenile, pediatric, less than 18, that 30 to 35, you can directly rule out systemic onset GIA. Then you come to SLE. Do you think this is SLE? Fever is there, arthritis is there, okay, can fall into SLE. Decrease CD25 expression, nothing related to SLE, never Right. Salmon colored rash. Again, that is also not there. So that is also ruled out. So ruling out, you can definitely rule out this HLH. Again, if HLH occurs in a systemic onset JIA, then you can, think about an HLH. But here again, there are no cytopenias, there are no lymphadenopathy, hepatosplenomegaly, nothing with respect to, except this soluble CD25 expression that can happen in HLH. You may get confused, but nothing else is there. Whatever, if you remember the Ravelli criteria, then also if you put this patient into that criteria, you will not get it fit, right? So except fever and decreased CD25, there's nothing. I agree, we have not discussed JIA. Obviously, I did not expect adult NEET SS question to contain GIA. Now, after once this has been asked, we definitely put the GIA videos also into the rheumatology videos. But before that, obviously, we didn't discuss on the app specifically with respect to the videos. So, evanescent rash, generalized lymphadenopathy, hepatosplenomegaly, serositis, these are what are there. But I did put it on the group, I think a few months before. Criteria for diagnosis of adult on the Still's disease, Yamaguchi criteria is important. So, this also, it's an important question now. Now we'll obviously discuss GIA, but yeah, GIA, I had not discussed this properly in our proper NEET SS adult lecture, so that also we should do. Then you come to NEER's impingement test. This is a previous year question. This is NEET SS 2021. Right. So this is previous year question. This again we didn't discuss in the regular videos. I discussed this in the elite. This is direct repeat question. So this also is something that you should not miss. This is rotator cuff impingement, or you can call it any impingement syndrome basically. It is yeah, so subacromial impingement or any rotator cuff impingement, NEER test is done. Again, you don't need to know all the tests. This is something that we discuss in our group also, that there are so many tests what to read. So this is the list that I had prepared and shared multiple times in our group. So this is all you need to know, many of which you would obviously know, I'm sure. Finkelstein, Fallon's, Tinel's, Adson's also, it's something that almost all medicine residents do know. So these are easier tests that have been asked before, but these are somewhat newer tests. So these are something that you can spend a little time on. Procedure, never they have asked. Only it is the purpose that is usually asked in your MCQs. Now coming to immunology, I think immunology again, there will be overlap. Some may come from hematologists, some may come from, maybe this had come from oncologists. So again, there will be overlap, but again, usually immunology comes into rheumatology. So I've put that here. So cancer associated cachexia. Initially, I was a little bit scared when I saw options of IL-1, IL-6, TNF, all were given. But later, after some clarity, only TNF alpha out of these three acute phase reactants were given in the options. So even if IL-1, IL-6, something was given, best answer is definitely TNF alpha only. And this is also something that we did discuss in our immunology lecture. So TNF alpha causes cachexia in malignancy. Tumor related products, interferons, nothing to do as such directly with cachexia. Hormones maybe, but not the major driver of weight loss and muscle loss in your malignancy. Mainly it is a TNF alpha that causes cachexia in your malignancy. Th2 inflammation, very simple question. IL-4, IL-5, IL-13, to some extent IL-6 also. This is your main cytokines that come from your Th2. Again, this was again not a very tough question, I would say. Maybe coming from an immunology background, I might be feeling it's easy, but this is, as such, if you look at cell mediated immunity, this particular image is something that is the first thing that you should read. This is something that is very commonly asked in with respect to your cell mediated immunity, right? So this is okay. So about easy to moderate only, I would say. So Th1, it is usually gamma interferon IL-2. Th2, it's usually IL-4, IL-5, IL-13, mainly to some extent IL-6. IL-17 and IL-22 come from your Th17. So this is a very important slide. If somebody is, looking for your looking at this recall for your next year's exam, then definitely you can keep a screenshot of this, because this is repeatedly asked in your INSS general also. This is repeatedly asked. So this was, I think, maybe the toughest or the most ambiguous question of the paper. So clippers is definitely not. Clippers and SLE you can directly rule out. I would say I'm not really sure with respect to the answer to this question. Directly depends on the age, I would say, because if it is a child or a teen, definitely it's better to go for C1q deficiency, because if somebody is developing recurrent cutaneous infections, even autoimmune thyroiditis is something that would put more into your CVID. It is very less in your C1q deficiency, unless there is some SLE and there some association, but nothing in your, even in your major books also it's not been written. So autoimmune thyroiditis puts it somewhat into your CVID. And also when age is not mentioned, I would assume, if you assume this to be an adult, then I would say CVID is a better answer, because see, peripheral neuropathy, it can occur in both. Normal immunoglobulin levels, yes, CVID is slightly excluded, but CVID, many, at least like 10 to 20% of CVID phenotypes are there with normal immunoglobulin levels. Recurrent cutaneous infections, again, seen in both, right? So peripheral neuropathy, recurrent cutaneous, you remove. Normal immunoglobulin levels towards C1q deficiency, autoimmune thyroiditis towards CVID. Low C3, again, low C3 can be seen in both depending on whether there is SLE or not. Simply C1q deficiency will not have a low C3 level. If there is C1q deficiency with SLE, with that immune complex generation, then only low C3 will come. So that SLE can be in CVID, SLE can be in C1q deficiency. So this is also not important. So the two main ones are your autoimmune thyroiditis that push it towards CVID, and your normally immunoglobulin levels that push it towards your C1q deficiency. So I'm not really sure what the answer is. If age was given, I didn't get the recall for the age, then I would say if it is child or teen, C1q better answer. If it is adult, CVID better answer. So we did discuss CVID, but obviously not at this depth. You cannot discuss CVID and see whether there's peripheral neuropathy or not. When I did go through a little bit of literature, peripheral neuropathy can occur in both. CVID also, it can occur C1q deficiency slightly more in your CVID, simply because CVID is a more common disease. But again, I would not say it's a good measure to say that the answer is CVID. C1q deficiency also, to be very honest, do not start reading about C1q deficiency now, right now. I don't think that will be asked. The only thing that you should remember is that it is associated with SLE, and autosomal recessive inheritance is the thing that can occur. So this definitely you can go through because it's a repeated topic now. Previously it was not asked, now it has been asked, so now it becomes a repeat. So low complement, again, low complement was also given. Low complement is slightly more in your CVID because it is more associated with your autoimmune manifestations. So not typical unless SLE activity is present. So that is again another thing that pushes towards CVID. Peripheral neuropathy, nothing as such. Age of onset was not given. Immunoglobulin levels slightly towards your C1q deficiency. Again, very ambiguous question. I'm not sure. Autoimmune thyroiditis, recurrent infections, autoimmune thyroid is something that pushes towards CVID, but again, other things are not very clear. So if age is not clearly pediatric, then CVID becomes better fit. There is no classic SLE also here. That is why also I feel if ever the examiner wants to choose one option, I would say CVID he will choose. Because firstly, C1q deficiency is not something that is very common, not asked also much. When you think about examiner's perspective, do you think that you will put a question on C1q deficiency for a NEET SS, right? It's asked in pediatric rheumatology INSS questions. So for NEET SS adults, very less likely that an examiner is coming and thinking of putting a C1q deficiency question. So that is why I feel if examiner wants to, I would hope the examiner puts these both answers for a +1. But if the examiner wants to put only one answer, then it will be CVID. I'm pretty confident that it will be CVID. So again, this also, if there are some option discrepancies, you can message me. But among these, definitely your leukotriene C4 is your best answer. Slow reacting substance of anaphylaxis. This is what we discussed in our hypersensitivity, type 1 hypersensitivity. So membrane phospholipids, arachidonic acid, PAF. Among this, mainly PGD2, prostaglandins, leukotrienes. These are what will cause your bronchospasm. So even your newly synthesized, yeah, this come a little bit late compared to your histamine, heparin, and your other chemotactic factors like eosinophilic chemotactic factors. These prostaglandins and leukotrienes come a little bit late because they are newly synthesized. So that is one thing, and these are the main ones that causes increased bronchospasm and increased smooth muscle contraction, vascular permeability, etc. These are so first and fast type 1 hypersensitivity. Among these, again, the first initial ones are usually histamine, etc. They cause your vasodilation, etc. Later, histamine proteases are your initial ones. Later, your membrane phospholipids like your PAF, leukotrienes, prostaglandins, all of these come out of these prostaglandins, leukotrienes cause your bronchospasm. And even later, the late phase is usually done by your eosinophils. That is also an important part. So these are the main ones. Lipid mediators lead to your bronchoconstriction. So this was one question that, to be frank, we did not discuss anywhere. I never felt that mastocytosis can be asked in this much. It's not very deep as such, but it's not a topic that has been asked before, at least as far as your rheumatology, NEET, etc. is concerned. Maybe this was asked from by an oncologist. Maybe, who knows? Basic question was systemic mastocytosis. So simply put, cutaneous mastocytosis is diagnosed by your cutaneous skin biopsy, while your systemic is diagnosed by your bone marrow biopsy. So you definitely need your bone marrow biopsy for a diagnosis of your systemic mastocytosis. This was what was mentioned. And I think one of you had messaged me around a month or so back that what to read in mastocytosis. I just told him or her to just go through the tables. So we did discuss in our allied series, we did discuss B and C findings, because this was something that was asked in your older NEET SS patterns, and I gave you mnemonics also. But in your classification is important, obviously. Just the tables, three tables are there in your mastocytosis. Even if somebody read just those three tables, also he would have got this. He or she would have got this correct. So diagnostic criteria of systemic mastocytosis, confirmatory major criteria is your mast cell infiltrate on non-cutaneous bone marrow tissue. So I think one of the options were skin biopsy. I'm not sure if this was the option. Somebody was telling options were this, both are combined options or something. But even if there was skin biopsy option also, that is not the correct one, because for systemic mastocytosis diagnosis, you need mast cells more than equal to 15 in your bone marrow or extracutaneous sites. So it's not the cutaneous sites, it's the extracutaneous sites. So this was one topic that we didn't discuss. I didn't expect also that this would come. Otherwise, you can go through our lectures and cross check also. I think 28 out of 29 questions we did discuss in our normal regular lectures only. So I would say the paper was obviously, as we discussed, rheumatology weightage is increasing. Initially it was 10 to 14 to 29. Now I don't think this 29 will stay. 29 is clearly too much. I think 20% of medicine is not rheumatology. So it won't be so much, but definitely I think it has increased a little bit, especially with respect to these blocks. Whenever there are blocks, everybody is putting some rheumat questions here and there. So it would be, I think, around between 15 to 20 that would be there out of 150. So paper was tough. Rheumatology, especially if you look from our perspective, what we have discussed, what we have studied, I think it was moderate to tough. I think except mastocytosis question, all the questions you can definitely attempt. You can easily rule out two options in all other questions. So I think it was moderate tough with respect to rheumatology. Overall paper, again, I'm not clearly gone through the entire paper, but what I've heard is that paper was tough. So hopefully the cutoffs come down this time, and rheumatology, I think you hopefully scored well. So again, if you look at it, I would not say it was pure Harrison based. Even if you look at all the questions, it's not picked up from Harrison, like wherever. For example, mastocytosis question, it was directly picked up from Harrison, but there were a lot of questions that were not picked up from Harrison directly. So it was reading Harrison line to line is again not the way to go, I feel, because it's not just rheumatology that you have to cover all subjects. So reading line to line, and more importantly remembering that, is pretty tough. So I think you should focus on these clinical topics that we discussed, which were asked asked repeatedly and which are clinically important. For example, rapidly progressive ILD, prognostic markers. These are topics which are not, clearly mentioned in your Harrison's as a prominent topic, or they're not put in tables, they're not put into bold. So those kind of things you have to, try to catch. Obviously, our lectures cover most of that except mastocytosis, that maybe I could have put in our group that we missed out. Otherwise, most of it is covered. And what another thing, three repeats were there. Firstly, that near test was direct. I'm talking about direct repeats, not repeat topics. Repeat topics many are there, but direct repeats three were there out of these 29-30 questions. Near test direct repeat, fibromyalgia case scenario. You can go to our 2021 recall. There you can see direct repeat. Keratoderma blennoragicum, direct repeat only. Their image was given, your image was not given. So that is also direct repeat. So repeats are also important. They're important not just because three is a large number. It's okay. Three is not a very large number, but if you look at the questions, especially if you look at near tests, there is a possibility that you may miss it out, right? So there's a possibility that you might not have read it, or you get confused in the options, you marked it wrong. So for those uh, you know tough questions which are repeat, those you should never miss. Those are things that you can just repeat questions. I'm talking about NEET tests. There are only two NEET tests papers that we're talking about, just 300 questions, right? At least those 300, and now for future aspirants 450 questions that you have to be very, very thorough with. LIT also, I have noticed there are so many questions. I've not looked into LIT I've not only looked at our regular videos only. LIT there are a lot of topics that we discussed. Questions obviously direct, I'm not sure how much came, but topics which were discussed, so many of them. C1q deficiency, we had at least touched upon. All of those were discussed. So LIT and your regular videos would have easily covered 28 out of these 29 questions. So again, I hope the options were correctly recalled. That is one thing that we usually get as criticism after this recall paper. Obviously we have not given the paper. These are all what students have told us. If you feel there are any changes, you can obviously message us in our WhatsApp group.